Hello, everyone. I hope that you're doing well. Welcome back for another round of test tips, RT test tips on Tuesday. Exam season is upon us. Many respiratory therapy students are getting ready to graduate. They're going to challenge the TMC and the CSE exam. So I want to put a couple of practice questions up that might review some of the information that you've covered way back when in your respiratory schooling. So I've got three questions that we'll go over today. But given that we are in exam season, make sure that you are aware that when you take the TMC exam, 160 questions total, 140 questions are scored for you or against you. There are 20 test items in there, and you have roughly 180 minutes. You have 180 minutes to take that exam. So roughly a little over a minute or so per question if you're looking at that. Then when you take the clinical simulation exam or the CSE, you have 4 hours to take that. There's 22 cases that you'll take, with 20 of those being scored for you or against you. Do remember that when you're taking the TMC, if you select answer choice A and you meant to select D, you can change that on the TMC. However, on the clinical simulation exam, when you're going through, make sure you pay attention to the verbiage that's provided, and if it tells you to select as many as you think is appropriate, or if it tells you to select only one answer choice. Unless otherwise directed to do so. So you may have a very scenario where the physician agrees or disagrees and they ask you to make another selection. So that'll be important too. So make sure you pay attention to that verbiage. But most important to note, with the clinical simulation exam, once you click an item or once you select an item, it's you can't undo it. Whether it's the correct item or the incorrect item that you clicked, make sure you're paying attention to what you're clicking, because that is going to be uh, you can't unchange it. So with the TMC exam, if you change your mind from answer choice A and you want to pick D, yeah, you can do that. But let's say you wanted to assess pulse oximetry on the clinical simulation exam, you click it and then you say, well, I shouldn't have clicked that. Once you click it, it's a done deal. So make sure 100% that what you're clicking for that CSE is pertinent or relative to the bit of information that you provided. So, exam season being upon us, just wanted to kind of lead with some of that. I've got three questions that we'll go over that should hopefully be helpful between my first and second year students as they go through this. So, we'll start off with this one. A hypervolemic patient is with congestive heart failure, or CHF, is administered a diuretic agent. Which of the following best explains why the diffusion capacity increases toward normal following diuretic administration? So now we've got to think about gas diffusion. So we know that we want, and with the pressure gradients that have to be involved with the ability of those gases to diffuse across the pressure gradient. And typically those are going from an area of high pressure to an area of low pressure. So we know at the lungs, CO2 comes out of the blood and into the lungs so that we can exhale that. And we know when we inhale, we're bringing in oxygen, the 21% oxygen that's in the room air that you and I are breathing, that is going to go into the blood and be delivered down to the tissues. And then at the tissues, there's got to be a pressure gradient again where that oxygen can offload from the hemoglobin, get into the tissues, and then the CO2 can offload from the tissues and get into the hemoglobin and be retransported back to the lungs so that when you exhale, you blow out CO2, you breathe in the oxygen again. So at the alveolar capillary membranes, is essentially what this question is asking about. So it says that you've got a patient that's hypervolemic and congestive heart failure. So now you've got to remember a little bit about your pathophysiology and be able to apply. So what all is going on? We have a patient that's in congestive heart failure. So we have a situation where the left heart is unable to move blood forward out into systemic circulation like it's supposed to, and then that blood that the left heart would or the left heart receives its blood supply from the lungs. So if you have a situation where the left heart can't send the blood out from the left ventricle like it's supposed to, yet we know that blood flow is an ongoing cyclical process, then that's going to cause some of that blood to back up into the lung vasculature and cause some pulmonary congestion. So you're going to have fluid accumulation. You're going to have the onset of pulmonary edema, which is going to be problematic, and that is going to have an impact with the ability of the gases to diffuse back and forth across the alveolar capillary membrane. And specifically, it's going to impact the ability of oxygen to diffuse back and forth across that alveolar capillary membrane. So we're saying that you're given a diuretic agent. What does a diuretic agent do? It's going to rid the body of excess fluid. If you have congestive heart failure, do you likely have excess fluid? Yes. In the question stem, it tells that the patient is hypervolemic. That means they already have excess fluid on board. So the diuretic agent should hopefully help remove that excess fluid, which should hopefully help improve upon our ventilation and perfusion matching. But also by removing that fluid, it should hopefully help decrease the diffusion path length. So that's some of the anatomy that we've got to think about before we even look at the answer choices. We understand that our hypervolemic patient, congestive heart failure, and they're given a diuretic agent. It says, which of the following explains why the diffusion capacity increases toward normal following that diuretic administration? So we've got a situation where this is impacting our the ability of oxygen to diffuse across that alveolar capillary membrane. So we already mentioned that we would hopefully experience an improvement in ventilation and perfusion matching. So you've got answer choice A there um, as a potential answer choice, but I'm not going to bite on that just yet because I want to look at the rest of my answer choices. Am I hopeful that my that I would get an increase in ventilation and perfusion? Certainly should. But again, I'm going to look at B, C, and D before we move it. The diffusion path distance is decreased. So the diffusion path distance being decreased, I've got to remember in my mind uh, what is listed in the question stem, would that cause an increase in the diffusion path length? That uh, excess fluid certainly could and will increase that diffusion path length. So I'm liking B2. So A is a potential answer choice, B is a potential answer choice. We'll go red blood cell uptake enhanced. That's not really going to be a bit of a situation that we're going to be concerned with. So mark that one out. And diffusion surface area being increased, probably can mark that one out as well. So I'm going to go through answer choices. Uh, it talks about which of the following best explains the diffusion capacity and that it increases toward normal. Well, the low VQ in of itself, although that may be corrected, is not necessarily the situation that is going to be that's going to improve the diffusion capacity by administration of the diuretic therapy. So, because the question is asked specifically about the diuretic administration and the diffusion capacity increasing, while the low VQ should be improved after we do that, that's not the reason for the improvement in the diffusion. So the improvement for the diffusion or the diffusion capacity is going to be that diffusion path length is decreased because of the removal of that excess fluid. So B would be the correct answer for that question. So let's clear the drawing and we'll move on to the next item. So here we see that we have the length of the diffusion path may be increased by which of the following. So this is kind of piggybacking off of what we had just looked at on the previous slide or the previous question, but it says the length of the diffusion path. So we have to look at, I'll try to draw it here. Maybe I'll go up here to the top of the screen. So if you have your alveolus, we know that there's also blood vessel, and there shouldn't be that gap there. You have to bear with me. Um, Drawing the capillary network that goes around that alveolar unit, and again, that gap really shouldn't shouldn't be there. Try to fill that in. But the length of the diffusion path may be increased by which of the following. So we know that diffusion path is going to be, for the purposes of oxygen from the alveolus to the bloodstream, O2 going into the bloodstream. So the alveolar wall in of itself is going to play a role in the diffusion path. The capillary wall will play a role in the diffusion path. Any type of fluid that might be in the alveolus could cause an issue with the diffusion path. Any type of fluid in that accumulation in the interstitial space could cause an issue. So those are things that we remember right off the bat when we think back to our cardiopulmonary A&P. So we're talking about the diffusion length, what might increase it. So if we look at capillary vasoconstriction, that's the contraction of those capillaries and they basically close down, they squeeze down. That in of itself is not going to be directly involved with diffusion path length. So I'm going to mark that out as an answer choice. Interstitial edema fluid or interstitial fluid. Well, that was one of the very things that we talked about as we were going over that anatomy. So yes, I will include two in the answer choice there. Fluid within the alveoli. We drew that in as we were going over and talking about what it might be that could increase the diffusion path length. So yes, I will include that answer choice as well. And then thickening of the alveolar capillary wall. So if we were to have a thickening of that alveolar capillary wall, that would certainly increase the diffusion path length and would cause issues for the ability that oxygen to transport across the alveolar capillary membrane and into the bloodstream. So thickening of that alveolar capillary wall certainly going to be that. So I can exclude one from the answer choice because we're not going to include that. So anything that has one in it, going to get rid of. And I know that I've circled three, so D can be gone too. So with this multiple, we're looking at 2, 3, and 4 as the best answer choices for that question. And I hope the hearing the thought process on these helps to make a little bit of sense too. Let me clear this and we'll move on to the next question, the last question for RT Test Tip Tuesday today. Okay, so now we'll go through this question. The first two, all three were for my first and second year students, but the primary focus probably the first year students for the first two questions and will lead toward the focus for my second year students here. But did make mention today in class with my first year students how this very scenario could be presented to them in their ventilator coursework that we have coming up in the summer with them. So upon assessment of ventilator data from 1300 to 1500, it's important to be able to tell military time. So we need to make sure the healthcare documentation typically is done in military time. So 1300 will be 1 p.m., 1500 will be 3 p.m. So we're 1 in the afternoon and 3 in the afternoon. So about a 2 hour difference between the measurements that we're getting ready to look at. So upon assessment of ventilator data from 1300 to 1500, it is noted that the PIP, we got to know our abbreviations as well. That's peak inspiratory pressure, measured at 36 centimeters of water pressure and 43 centimeters of water pressure, respectively. So ultimately, if I'm looking at this, I can write out at 1300 and 1500, my PIP was 36 and 43. So the fact that it tells us that it's respectively lets me know that the first number is going to be associated with the first time. Uh, the second number be associated with the second time. So it says while the P plat, that is our plateau pressure. So if I have our P plat written down here, it tells us that that measured 33 and 33 respectively. So at 1300, that pressure was 33 centimeters of water pressure, and at 1500, at 33 centimeters of water pressure. So this says here, what can the respiratory therapist deduce as the potential cause for the change noticed in the pressures from 1300 to 1500? So what can we make essentially of that data that was provided? So if I'm looking at peak inspiratory pressure and plateau pressure, if you think about those numbers, PIP minus P plat, we're looking at transairway pressure with that. So and if you think back to anatomy and physiology, that's also airway opening pressure and alveolar pressure. So airway opening pressure would essentially be the pressure at the mouth, peak inspiratory pressure, while our alveolar pressure would be synonymous with our plateau pressure. You get that with a breath hold or an inspiratory hold maneuver on the mechanical ventilator. So this portion of the formula here is going to be our transairway pressure across the airway. And we also have to remember some of the normals. So if we're looking at, we also will utilize some of those terms when we're calculating compliance. So we know that for uh, ventilator data, we have things that can cause an increase in peak inspiratory pressure. We have things that can cause, leaks in the system, low pressures or what have you, low volume indicators. We've got different things that we can troubleshoot, and we can apply all that here. Now, it doesn't say squat in the question stem about anything about an alarm, and you don't need to know that with the alarms at this point. What we need to understand that there are things that can cause an increase in peak inspiratory pressure. That's going to be a decrease in lung compliance or an increase in airway resistance. So we have to try to figure out what's going to be the issue. So if I see that at 1300, my peak inspiratory pressure is 36, while my plateau pressure is 33, I have a transairway pressure here of about 3 centimeters of water pressure. PIP minus plat or transairway pressure. At 1500, the peak inspiratory pressure is 43 centimeters of water pressure, while my plateau pressure is 33. So the plateau pressure stayed relatively stable, or it is stable. I mean, it's exactly the same measurement 2 hours later, but my peak inspiratory pressure has increased. So I have a difference of 3 centimeters of water pressure here at 1300, and a difference of 10 centimeters of water pressure at 1500. So now I have to go back and remember the relationships with, do I have a decrease in lung compliance or do I have an increase in airway resistance? If this were to be a decrease in lung compliance, you would expect to see roughly that same trans airway pressure. So ultimately, you would see an increase in your plateau pressure and you would see an increase in your peak inspiratory pressure while that trans airway pressure stayed essentially the same. What we're seeing here is quite different than that. We're seeing that our plateau pressure remains relatively stable. So for all intents and purposes, we can deduce that our static compliance is for the most part unchanged, but yet we're seeing a significant bump and increase in our peak inspiratory pressure. That is the hallmark of an increase in airway resistance. So now that we've covered that, we can look at these answer choices and see what we have. So ARDS, airway resistance or lung compliance issue. Not to say that you couldn't have both, but it is primarily a restrictive disorder lung compliance issue. Pneumothorax, again, airway resistance lung compliance issue. Say lung compliance issue, you're going to have lung restriction with that. Pleural effusion, again, you're going to have more lung compliance issues, more of a restrictive issue. Bronchospasm, you have tightening of those airways, a reduction of the inner diameter of the airway by way of bronchospasm. Those muscles have contracted. That's going to make it more difficult for air to move in and out of the lungs. That is an increase in your airway resistance. So, based upon the data that's been shown and the answer choices available, and what I can remember about what I've learned through um, mechanics of ventilation, the use of peak inspiratory pressure and plateau pressure, I can decide that D is the best answer choice here. Thank you all for your time and attention today, and I hope that you have a good day. And yes, we are indeed in exam season, so the best of luck to you all as you are passing your exams. And if this has been any help to you, let me know. Let me know in comments or what have you, and I'll do my best to try to keep putting more content out there that might be helpful for you also. Thank you for your time and attention. Have a good day.